I'm going to be presenting information about blood glucose control in hospitalized patients. This is my capstone project, and I've kind of said before, everyone will have to present one of these. And so here we go. So what are some challenges that you guys face in your particular areas with managing patients in the hospital and the blood glucose values?
The food they're eating.
The food they're eating?
Or sleeping.
Or sleeping. Anyone else?
The procedures we do on them.
Yeah.
The steroids.
Yeah, steroids, medications, foods. So we're talking about like some non-compliance procedures, all that kind of stuff can like greatly affect how well we can manage the blood glucose values. So my objectives for this presentation is that you guys will be able to identify some effects of poor blood glucose control during hospitalization, as well as describe 2 recommendations from the American Diabetes Association to facilitate a good glucose control. Normally in the hospital, we have standardized times, and so that can really give us some challenges. I know for my hospital that I work at, we have ACHS, which is before meals and at bedtime, and it's like something, it's Latin. And so these times are 0730, 1130, 1700, and 2100. Well, the problem is sometimes like our care and the things that we do don't really line up with those times. And so we get put in the position of having to deliver our medications on time, or actually performing good glucose control for these patients. If a patient comes back from a procedure, they can eat, and it's 3 p.m., you know, it's kind of like, oh, we'll just wait till 5, and all of a sudden now you open up this door for blood glucose values to go all over the place and everything. And so you'll have to develop a pie code question. And so my pie code question is, in hospitalized patients with diabetes mellitus, how do glucose checks at time of meal delivery compared to conventional glucose monitoring at standardized times affect overall glycemic control during the admission stay? So the ADA recommends or advises that blood glucose values less than 70 milligrams a deciliter are considered poor glucose control values, as well as anything over 180 milligrams a deciliter. These ranges are there because outside of these ranges, we can have prolonged treatment times. Patients may have to go on antibiotics longer. I'm type 1 diabetic, and so whether it be strep throat or panicia, like in my foot or something like that, the doctors are immediately, oh, well, since you're diabetic, we're going to put you on Bactrim for twice as long because they assume every diabetes patient is poorly controlled. But it can have a very negative impact and cost to how we're caring for these patients. Another thing it can cause is a prolonged stay at the hospital. For those of you that work in the hospital setting, there's some nursing homes that'll say, oh, his blood glucose values have been above 200 all day today, we can't take him. And so these things cause a cost, and there are problems, and so it's extremely important for us as nurses on the front line in whatever setting we are to do our best to keep these under control. Another thing, my wife can probably attest to this one, when the sugar goes low, you need a Snickers. Okay, you're like a whole nother person. But in the hospital setting, this can cause a lot of problems. It can cause things like confusion, delirium, loss of control of their body. It can cause aggression. So these are all things that can end up turning into occurrence events, which are not good for a patient in the hospital as well. And all of a sudden you're on a whole nother rabbit trail of making sure they don't have any broken bones, no hematomas, anything like that. So poorly controlled blood glucose in the hospital can definitely have some negative consequences. Now, the ADA guidelines for good glucose control include blood glucose values being between 140 and 180. Now the reason for this is because they found that patients that are on a little bit higher level of control are able to sustain the stress that they may receive while they're in the hospital. And so what you're going to have is, they're going to go into surgery, they're not going to be eating for 6 or 8 hours. Let's make sure that we have a good buffer on their blood glucose so they're not dropping into the 40s or 30s during surgery. Another thing is the consistent carbohydrate diet. I think it was as of 1995, the ADA said no longer to use the diabetic diet. And it's kind of sad because when we're doing transfers of care and some other things like that, I'll be talking to the nurse on the other line and they're like, they're on the diabetic diet. And I said, well, describe to me what the diabetic diet is. And they're using guidelines from more than 20 years ago. And that's not a good thing. In the consistent carbohydrate diet, we want to give the same amount of carbohydrates and calories at each meal to prevent fluctuating glucose values. Yep. And then obviously activity unless contraindicated. When you get these patients up and moving, activity for our hospitalized patients is one of the number one things if it's not contraindicated because of procedures or any kind of things going on with that patient. All right, so are you able to tell me one effect of poor blood glucose control in the hospital setting? Unless anyone.
That's great. Full-on hospital setting.
Okay, very good. Anyone else?
Delayed wound healing.
Okay, good. And are you able to describe recommended guidelines from the ADA for blood glucose control? Consistent carbohydrate diet? Yeah. Anyone else? What were those blood glucose values? Ranges?
140 to 180.
Yeah. Okay, good. So everybody knew that. Just no one wanted to raise their hand. All right. So I did a literature review on some studies that were published, and so I'm just going to go over those with you and kind of tell you where I got a lot of this information from. So a systematic review of descriptive studies was conducted by authors Ryan and Swift in 2014 on the challenges of coordinating meal delivery with blood glucose monitoring and insulin administration. So basically these two at their hospital were like, we have a problem. We're checking blood sugars at these meal times, and then insulin's not being delivered to correct whatever these blood glucose values are. Sometimes, I think the furthest away they were finding insulin being given almost 2 hours and 45 minutes after the value was actually taken. Yeah, and so this was a hospital-wide problem that they did from ICU, med-surg, oncology, and they combined all this information together. And then they did a systematic review of best practices from other researchers. And so another one that I looked at was a single descriptive study, which was actually a quality improvement program performed by 6 different nurses and dietitians at another hospital, and it introduced a change of the workflow of the dietary and nursing departments. What they found was that this isn't something that can just be done by one discipline. It was something that was really going to require multiple disciplines in the hospital to be working together to get these ranges in the appropriate space. So you have 2 different studies that were done, and these are some things that they recommended from the 2 for nurses to do. The first one was keep the time from meal delivery or from glucose check to insulin administration under 30 minutes. And that seems really, really difficult, right? Because I think for a lot of us, we have our technician take the blood glucose, and then we either wait for it to pop up on our screen, or we wait for them to call us, or we go to the room because they wrote it up on the board. The problem is that this is not real-time care for these patients with diabetes. Think about just even human error. Let's just put human error in there. If you're getting your blood glucose value off the board that the tech wrote on, what if they're dyslexic or they wrote the wrong number or something like that? then you have a whole list of problems. Or they don't call you because they're doing a patient's bath. So these are things that we really have to keep in mind and can actually cause these ranges to go out of control and then increase the length of stay for this patient. Another thing, as a nursing intervention, was a meal delivery process change so that nurses are at the bedside to check point of care glucose levels and dose insulin accordingly. If the nurse checks the blood sugar, and it's difficult because at my hospital, we have to go to the Pyxis, dose the insulin, and then bring it back to the room. However, at this particular hospital, the nurses were allowed to carry the insulin with them. But if the nurse grabbed the level, they didn't have to worry about miscommunication. They could immediately go right from the patient's room, get the appropriate dose of medications, and be there as the food's getting delivered. So it was a very, very interesting process to see. And although it took a lot of people to bring it together, when it did bring together, they went from, I think it was like 76% of their patients falling into ranges outside of the appropriate or standardized values to about only 12% of their patients falling into those values. So the third one was bedside point of care blood glucose monitoring guides insulin dosing. In the patient receiving nutrition, glucose monitoring should be performed before meals to match food ingestion. I have type 1 diabetes, and I can tell you right now, food starts breaking down up here. And you'll probably learn some of that when you get into the GI part of your patho, that your body's already working, enzymes are pushing out the moment that food hits your tongue. Well, the thing is in a patient with diabetes, everything else is working appropriately. Only thing is their pancreas isn't putting out that insulin. So if they're starting to eat, you've already checked their blood sugar, or if you check their blood sugar after they started eating, their dose for their meal and then their dose for the correction are not going to be appropriate. So you may actually end up over-medicating or under-medicating your patient. And that's definitely not an area that we want to get caught in as nurses. So just the conclusion of everything, insulin administration is greatly affected by the timing of blood glucose level checks. So,
Carol Nielsen?
Yes.
Oh, Jesus.
It's okay, he's doing the presentation.
So again, insulin administration is greatly affected by the timing of blood glucose level checks. It's extremely important that you as a nurse, if you're working in the hospital, I know some of you may work in outpatient settings or in nursing homes or different areas, you really have to reduce that time that you're spending from the time you're checking that sugar and then correcting if it's needed. It really allows the patient to remain in those values and really improve the outcomes for whatever they happen to be going through during their hospital stay. Blood glucose checks should be taken immediately prior to meal consumption. I have this thing, it's called a Dexcom, and so it checks my sugar every 5 minutes, right? It's amazing how much your blood sugar can change in 5 minutes. I mean, there's some cases, if I have leftover insulin or something like that, that it may drop 20 points in 5 minutes. So imagine if you have someone and you check their sugar and they're 180, and like my hospital requires that we give 2 units of insulin for anything over 150 and under 200. So I give that patient 2 units. But if for some reason there was some leftover insulin in their body or something like that, in 5 minutes their blood sugar could be 160, and in another 5 minutes it could be 140, which wouldn't require any insulin coverage. So we want to make sure that we are doing these consistently throughout the day as to not overlap insulin administration and other things. Because does anyone know how long insulin stays in the blood? Like the Humalog or the Novolog that we give?
It's fascinating.
15 minutes or 15 minutes?
So it starts in 15, but how long is it hanging out there?
2 hours, 1 to 2 hours.
4 hours.
4 to 6, depending on, I think they've found that like Humalog is more on like the 5 to 6 hours, and Novolog is about 4 hours in the bloodstream. So that's a long time. In a scale like your ACHS, where you're doing a 7:30 and 11:30, if you take your 7:30 late and your 11:30 early, you may still have some leftover insulin from your morning dose. So it's extremely important that we're doing these on time, appropriately, right before meals. And again, that just leads us into ACH policies may be outdated or need revision in our hospitals. And so it's something that, like, when you're performing care for your patients, I'd hope that you really pay attention to. And if you get the opportunity to be on something like a med-surg practice council or ICU practice council or anything like that, you know, you might want to take a whack at seeing if there's any opportunities for improvement where you are. Are there any questions?
Slightly related, but not really.
Okay.
So what's your opinion on hospital policies that they have to remove their insulin pump when they come on the floor?
Okay. So number one, I know that hospital policies are there to protect me and the patient. Obviously, the patient first. So, you know, if for some reason my facility has that policy, I'm not going to go outside of it. But insulin pumps are extremely tricky. And so, me being a nurse and a type 1 diabetic, I cannot believe that some people are able to operate these devices. And so it would, although some people may be able to do it very, very well, I think it is in best interest for the patients during hospitalization that they are removed. I mean, 100%. Because I'm gonna tell you right now, if I gave my nurse like this stuff and I'm like, hey, this is what I'm doing, she's gonna look at me like she doesn't know what I'm talking about. Because the way that like my ratios are completely different, my insulin administration is completely different, and she has to document like, well, this is what I ate, this is how much insulin was given, because they have to record how much insulin was administered. You know what I'm saying? And so like that, and every person that has diabetes, if they are very active in their care, it's gonna be very different for each person.
But having that insulin pump, doesn't that keep your blood sugars better regulated?
It does, but my control levels are gonna be different from what appropriate control levels are if I'm in a hospital. You know, like I'm not gonna keep my blood sugar between 140 and 180. Like my goal is like 100 to 150. So, but if I'm in a hospital setting where if I just had surgery or something like that, I'm gonna need a little extra help, like keeping that up a little bit. Because the last thing I want to do is be sleeping, I press my call button, my nurse comes 15 minutes later, and I'm in a coma. You know, I mean that's the reality. That's the reason why like oral anti-diabetics are normally held at things, because you can't control what they're doing over that time that it's in the patient's bloodstream. Did that answer?
Yeah.
Okay.
I mean, I was an ER nurse, now I'm a hospice nurse, so I don't know anything about floor nursing.
Got it.
So in the ER, we're like, it's really high, okay, we're gonna do something about that. Even if it's 200, we're like, you're good to go,
Yeah.
here's some fluids, you go to the floor. And you guys deal with that, so, and I know, I've known people that, I know because you have those pumps that your blood sugars you're much better regulated. So my concern is, you've got something that you've got it under control, and then you come in and we're like, take that away.
But see, the difference between me and another person is I have the perspective of a nurse as well. So I know that if I'm gonna stay 150 to 250 in the hospital, that's gonna be okay. Somebody who has worked for the past 10 years to get their A1C and their blood sugar down is not gonna be as receptive to that, you know? So I can understand that, and you were asking me like how I feel about it, and so I gave you how I feel.
Right.
But it is more important for us to have a hand in what's going on with this patient's medical care. And, you know, obviously if they want to give their own shots, all that kind of stuff, yes, like give the patient the autonomy to do those kind of things. But when that patient is bottoming out and you're having to call a rapid and get, you know, 2 amps of D50 and all that kind of stuff because the patient overdosed and they were on a medication that they didn't know that influenced their blood glucose levels, you know, then you're in a whole nother basket of trouble. Yeah. Any other questions?
Good job.
And then if you just fill out those things, it shouldn't take more than a couple minutes. And I'm sorry, I meant to say you could do them while I was gone. I apologize.
Can you give them, thank you, can you give them any